Welcome back again to the Haitian Community platform. We have a special guest today. And I think that traditionally what we normally have on the platform are Haitians or people who have actually resided in Haiti. We had a person that started a nonprofit to help small businesses and help people get educated in Haiti. But today's a real special case because I was gunning off all the people in my family that have problems with what we're going to talk about and how the community is seriously impacted by diseases and health issues that are condemning people to a poor quality lifestyle, being able to be active, right? And we all can't be LeBron James, right? And I was saying earlier to someone, from the minute you could start running as a baby, you run until you're like a teenager, and then you sit down for the rest of your life. And once you start sitting...
That's a very nice way to put it. Yeah.
Right?
Yeah, I never thought about it.
Yeah.
That makes sense.
So for LeBron to be 39 and still running is way
feat.
past his bedtime for that, right? And one of the things that happened is we start having problems. And it is a wonderful opportunity to talk to someone such as yourself that addresses some of these major issues. So thank you so much. And why don't you tell everyone who you are?
Perfect. So, hi, everybody. Very nice to meet you. I'm Oscar Quintero. I'm a physician. And I'm basically training general medicine. And I have a particular love and affection for cardiovascular disease and peripheral vascular disease, which is mostly what we're going to try to focus today.
Right.
And it's the reason that you invited me today, which
Absolutely.
I'm very grateful, by the way. This is actually my first podcast. So if I do something wrong, just let me know.
You already did. So you can get that past you. So you're fine now.
Sorry, guys.
And it wasn't that bad.
All right.
Yeah,
there
see?
we go. Okay.
Yeah, so you're
I
fine.
popped my cherry right
You
here.
didn't do anything. I'm just playing with you.
Anyway, and I feel very grateful to speak and just relay the message about cardiovascular disease in general, right? So especially in the Haitian community. So I work with Dr. Pedro Martinez Clark. He's an interventional cardiologist, and he has a lot of experience with cardiovascular disease. And on his private practice, we have the opportunity to see different kinds of patients, mostly Hispanic patients, as we are in Miami Dade, of course. But something that I was not very trained in, because I actually did most of my training in Colombia. I never had the opportunity or the exposure to Caribbean patients from the Caribbean, and mostly Haitian patients. And when you come to Miami, that's one of the things that you find out the most, right?
Such a melting pot here.
Exactly. And one of the things that about medicine that is pretty particular is that medicine changes, and the diseases that you're exposed to change depending on your culture.
Right, the food, the climate.
The way people see exercise. And I got a really good example for you with Haitian patients that I've seen is very particular. So being exposed to that out of the blue and seeing that it's such a population, a community that has really high risk for several cardiovascular diseases, really opens your mind on how you want to try to interact with them and make sure that you convey a message that is understandable to hopefully modify those risk factors and have healthier communities and a healthier population. So during this couple of years, I've been working with Aramavita and with Dr. Martinez Clark. One of the things that you see is that you get a large community of Haitian patients that it's already a challenge to interact with these patients.
With the language barrier?
Yes, mostly that. We're very fortunate that in our practice, we have several medical assistants that are Haitian.
Right.
They speak Creole, English, Spanish. They're geniuses. It's amazing. I don't understand how they
We
do
all
it.
should be speaking all three languages, right?
Absolutely.
Right.
I absolutely agree with you.
Yeah.
And I've tried personally to do the exercise, be like, okay, Pascal is not here. So let me just try to speak with this patient. And I feel frustrated for the patient because you see that they're trying to really tell you what's wrong with them, but it's so hard.
The language barrier.
Yeah.
Are you using Google Translate?
I tried,
Right.
but it works better if it's in French with the Creole setting.
It
honestly,
doesn't do a great job.
it doesn't make it any justice.
Right.
So as I'm telling you, in that sense, we're very fortunate that we have somebody, and actually, like our medical assistants have a lot of training, medical training, and they can translate in a very particular way the symptoms of the patient and put it in medical terms that it's easier for us to understand and make accurate decisions for the patients.
Yeah, because, within a language, there are subset languages, there are vernaculars, there are just a certain level of dialogue that takes place. You could be an English speaker your entire life and someone starts talking legalese, you're not going to understand anything because that's not something that you study. So then there's the level of education and familiarity with the person that you're speaking to in that target language. So having the right staff is imperative.
Absolutely.
Just across the board. So let me ask you, first question, PAD.
Yes, sir.
Peripheral arterial disease. What is it? Can you explain to the people how it affects the body and so forth?
Absolutely. So, peripheral artery disease is basically cholesterol and plaque buildup in the inner lining of the arteries outside of the heart.
Okay.
It can be anywhere. On average, we have used the term almost exclusively for plaque buildup in the lower extremities, I mean on the legs of the patients. So when somebody's telling you peripheral artery disease, they are specifically trying to convey plaque buildup in the arteries of the legs.
Okay.
Right.
Wow.
So something that is very interesting and why I am so passionate about peripheral vascular disease is that it mostly happens in adults, in older adults. And when you look at the statistics, it's highly prevalent. That means that a lot of people have it. But being able to diagnose it is a little bit complicated.
Right. Because
the presentation is very, very different between patients. So when you go to med school, they tell you, all right, a patient has peripheral vascular disease, right? So technically speaking, when they are at rest, they feel great. Then they start walking and they get leg pain. And when they stop walking, the leg pain improves. And that's what you see your general care providers, you see your cardiologists, you see your residents, your fellows, everybody who's into healthcare, your nurses, your PAs, you see everybody talking to the patients and asking them this question as I just framed it to you. And then patients are like, you know what? I walked like half a block and I felt great. So no, I feel fine. So patients, if you enclose the question in such a like a very specific manner, they are like, no, I don't feel it, right? And then a lot of peripheral vascular disease gets ignored or underdiagnosed because of that particular state, because that's how we as providers are asking the question incorrectly.
So it's small. It's not framed generically enough, or it doesn't have enough of a ingredient or ingredients to capture whether or not they understand what they're experiencing. Right.
And part of medicine, so I remember I was in medical school, they always tell you that medicine is science, but it's also an art form. It's the art form of communication, right?
Absolutely.
You have to connect with the patient. If you can't connect with the patient, it's weird. The patient won't trust you enough to tell you things. And sometimes they tell you things that you didn't ask them. So you'll be like, when you walk, do you get leg pain? And you'll be like, no. But you know what, doc? Actually, I do feel like my legs get pretty tired. Like my leg loses strength. I don't know how to describe it. And that's where you're like, that's peripheral vascular disease. So I think there's two components that makes peripheral vascular disease very difficult to diagnose. One is the way we ask the question, and the other is the way we relate to patients, right? And especially with Haitian patients, you got already a very difficult disease to diagnose, and now you got a language barrier added to that. So you miss a lot of peripheral vascular disease, which is highly prevalent in patients from Haiti.
So this is why statistically would you say that Haitians have this PAD issue above average?
Well, not just particularly because of the language barrier, but also because of the risk factors. I mean, almost everyone. I mean, I'm from the north part of Colombia.
Bogota?
No, northern part. So
Cali?
Cartagena.
Cartagena. Okay.
So when I talk to patients, I describe myself as Caribbean too.
Right.
I live like right in front.
Right.
I grew
You're not
up
too far
Yeah.
from Tobago and Trinidad and Grenada and so forth.
And if you see the things we eat, they're fairly similar. Like the rice, the beans, the pork, the
Right.
spices. I mean, of course, yours is better, but
No, I mean,
well, I like it more.
Colombian. Listen, my uncle is married to a Colombian, so I
Okay.
grew up with both dishes.
Uh-huh.
You know, and in Queens and Jackson Heights, there's nothing but Colombian cuisine out there. So it's very hard to say one thing over the other. The both are very delicious, but I'm sure they play a huge factor.
Absolutely.
Right.
Absolutely. So, and when you see patients with peripheral vascular disease and Haitian patients, a lot of them have a lot of hypertension.
Right.
They have a high cholesterol.
Right.
So all of these factors add up to that, right? So peripheral vascular disease gets underdiagnosed, and the worst outcome that can happen from peripheral vascular disease untreated or underdiagnosed is amputations
Oh, yes.
of the lower extremities.
Right.
Right. So peripheral vascular disease, that's like the worst thing that can happen. And then you got this like caveat that was very interesting. We got better medications, we got better surgeries, we got better therapies, we got better training for practitioners. But something very interesting happened. The American Heart Association kind of tried to shed light into is that the amount of amputations related not to car accidents or trauma, but to chronic diseases, hypertension, diabetes, high cholesterol, were increasing. It's like, okay, this doesn't add up. Like, we are better. Why are we having worse outcomes? It doesn't make any sense. And what they discovered is that, what I was telling you, PAD was being underdiagnosed. People are not caring for it, right? And then even a worse outcome was that it was this statistic for me is the most shocking one. A patient who receives a major amputation, that means an amputation above the ankle, they have a mortality, that means they die, at least 71% more in the next 3 years to compare to people who didn't have a major amputation.
Oh, yeah.
So if you think about it, an amputation is a terrible thing because people is like, oh yeah, you don't have a leg. But also, what if you used to drive for a living and now you get an amputation on your right leg? You won't drive anymore, you won't work anymore. Moving around is difficult. What if you exercise less, so you gain weight, and all your cardiovascular, like myriad of risk factors suddenly increases? That's why these patients are dying more. So this happened, and we saw that in communities that are more vulnerable to risk factors for plaque buildup and cardiovascular disease in general. So we saw that a lot in African American and Hispanics, and then you got Asians, which is like kind of a hybrid of both. And those risk factors, you definitely see it and I can tell you, when we see patients in our practice, definitely you see a lot of Haitian patients with peripheral vascular disease.
So my grandmother had diabetes, and she was living in Haiti, and she had to come to the United States to get her legs amputated, right? Okay. The first thing that I saw something on Instagram or YouTube, I always mix these little short stories. They say the first thing to render your life not yours, is to lose your legs. Because if you can't use your legs, you can't take care of yourself. You can't go to the bathroom. You can't go to the kitchen. You can't go to the supermarket, right? How relevant is diabetes and hypertension to PAD? Is it possible to have hypertension and diabetes without being prone to PAD?
Okay, that's a wonderful question, and I love the way you framed it.
Thank you.
The short answer is no. Like if you have either PAD, if you have hypertension and diabetes, you already twice as likely to develop PAD. That's it. Because everything correlates. Everything is connected. Right. So diabetes, especially diabetes, like smoking and diabetes are like the major risk factors.
Smoking.
Yeah.
For your legs.
Yeah.
Wow.
Yeah. Smoking. So what happens is that smoking.
Sorry.
No, my bad.
No, my fault.
Smoking promotes a lot of inflammation, and such is diabetes. And when we think of inflammation, we imagine like a bruise, in our body. Like, oh, if somebody punched me in the face, like a huge bruise.
Swelling.
Yeah, the swelling.
I think of food.
Yeah.
I think of the food that we eat and how inflamed and bloated we are from eating all of this food. I can see that impacting our legs.
Absolutely. So what happens if you're in a state of inflammation,
right,
you make the inner linings of your artery
acidic?
More prone to collecting the cholesterol that is floating around in the blood, right? So that cholesterol starts to build up until it blocks an artery, or if you like you get a 50, 60, 70, 80% what we call a stenosis, or a reduced amount of flow because of this particular lesions. And a cholesterol, high cholesterol, diabetes, hypertension, all these states promote inflammation. And you get plaque buildup, not just in your legs, like in your heart, in your carotids, you get inflammation everywhere. Some patients are more prone to develop these plaque buildups in their legs. That's peripheral vascular disease. But some patients get plaque buildup in their arteries. And it's very, very interesting because you get a lot of these patients who have peripheral vascular disease, and they come and they notice that their ability to walk is severely impaired. They can't move around. We had a patient that she was walking in the street and she just kept falling. And neurologists were seeing her, like cardiologists were seeing her, and nobody asked her about her legs. We found that she had blockages almost from the waist all the way down. Dr. Martinez did a procedure, opened up those arteries, and the patient improved significantly. And she never had an issue with her heart or with her brain. It was purely her legs.
Okay.
Yeah. And those
So she didn't have hypertension or diabetes?
She did. But the thing is that they are all connected, right?
Right.
These states, they are like the way I like to put it is they're like a snowball effect falling down a mountain. As soon as you start to develop these plaques, the process starts to accelerate and accelerate.
At that point?
Yeah. It starts to accelerate until there's a point like you got like a completely blocked artery.
Wow. Are we going on the record and saying that Caribbean food damages our microbiome and then enhances the probability of us having hypertension, having diabetes, having PAD?
That's a really good question. Honestly, I don't have the answer. I wouldn't say it does.
Right. Because people say, oh, when I go back to the Caribbean, when I go back to my country, the food there, I lose weight. I'm not as bloated. I don't have all these issues. When I eat in the United States, I gain weight. When I eat the same food abroad, I don't have these issues. But then again, I told you, my grandmother got her legs amputated. She did not live in the United States.
Yeah.
She had diabetes.
No, absolutely. So the thing is that also I think somebody who's, is Hispanic, I'm in a way I'm an outsider too. I think that the screening tools in the US are better.
Right, the screening.
Yeah, so we are able to diagnose more people. Like a lot of patients, you know what I mean? Like we are able to identify people sooner
Right.
And we start to treat them sooner. And there's like, hey, I was not diabetic in
How do you
Haiti,
know?
but now I'm diabetic in the US. So it must be the US. Like I have a really good example for this. When I was in med school, I had this patient and she had diabetes like for 15 years. One of the things about diabetes, it can leave you blind. It's called diabetic retinopathy. And it damages the retina. And this lady had diabetes like for 10 years, right? And she finally, her blood sugar was like terrible. She went she came to us, we started treating her. And then she said to me, I don't want to start insulin. I was like, ma'am, you don't have blood, you have maple syrup. You need insulin, okay? And she was like, I don't want to start insulin because this my neighbor, she started an insulin and she was blind the next year. It's like she was blind the next year not because of the insulin. She was blind because of 15 years, 20 years with diabetes that was untreated.
So there is a high level of miseducation because insulin is injected for the simple fact that your body your pancreas, right, no longer produces insulin, right?
Yes, it depends. So that's type 1 diabetes.
Okay.
Then you got type 2 diabetes that actually your pancreas is producing insulin. It's producing
overproducing it.
No. So your pancreas is producing a lot of insulin.
Okay.
But the receptors that allow to the receptors, because of the insulin is always elevated, they get damaged. It's like when you open and close a door 1,000 times, it will eventually get damaged, right? It's kind of the same story. The receptor is always being hit with insulin, so it gets damaged with time. So you need more insulin to start to activate it.
Yeah,
it's like one of those doors, like I was telling you, just gets like when you open and close, and then the doors like gets like slanted and it's like scraping on the floor.
Right.
You have to push it harder.
Right.
Kind of the same way happens with type 2 diabetes, which is the one that most of people have. When they're older, they have terrible diets, they have high amounts of insulins, and we call that hyperinsulinemia. That means high levels of insulin in the blood for chronic amounts of time, for years and years and years. That's when you get the type 2 diabetes.
So, I read this book. I mean, there's a series of them by this guy named Dr. Stephen Grundy.
Oh, yeah.
And the last book I read was The Plant Paradox. And he gave the example of what the job of insulin is, which is to, in a way, some of the job is to clean the blood, right? To remove sugar and things of that nature. But then after a while of being oversaturated, eating too much sugar, that the body now has a problem with cleaning the sugar out of the blood. And henceforth, this example of her blood, a vampire would love her, right? She'd be like candy to them because she has so much sugar in her blood. And she thinks insulin is actually the problem when she's already created the problem, as well as her neighbor. Hence.
Yeah, and the thing is that one of the things that makes us human is that we are able to recognize patterns, right? And the way people see it is like, oh, she started insulin and now she's blind. So if I start insulin, now I'm blind. But the thing is that people don't understand like how science is made. And science is not one person, it's thousands, millions of people who have tried insulin. We have thousands and millions of people who have tried this particular medication, and we see the side effects, we see how it works. And that's why we give you recommendations. Right? Actually, if you go to a doctor's office, the way they should address, like, you come to the office and be like, hey, I don't want to start losartan because it's a medication for blood pressure, because what about the side effects? And what we usually see the patients, and what we usually tell patients is that, look, we're giving you a medication that is being tested not by me and my cousin, but like millions of people, 10 millions of people, 20 millions of people, 20 million people, more and more and more and more. So you might have side effects because, there's always a possibility for something happening. But the likelihood of you having that side effect is minuscule.
The prerequisite in actuality, in many ways, is the fact that their lifestyle already led them to
Exactly.
taking medicine.
Mhm.
So having a conversation now about patients being in your office.
Mhm.
Let's talk about what led them to get to you first, right?
Mhm.
Because obviously you're never going to be able to stop this problem by yourself, and you're there to solve it. What are leading or landing people in that hot seat?
That's a good question. So basically, all the things that promote a and risk factors for cardiovascular disease in general.
Right.
So sedentary lifestyle.
Sedentary. Can you
yeah.
define that? Because in
So-
the United States, everyone's sitting down all the time.
That's true. So what the American Heart Association, they are they have very nice definitions about everything. So you'll see me quoting them a lot.
They massage the answers. And,
It's easier. I mean,
right.
so they describe that on average, a person should perform two types of exercise. They should perform cardiovascular exercise, and the minimal amount, not the best, but the minimal to have a healthy cardiovascular system and to prevent cardiovascular disease is that a person should do at least 150 minutes of exercise weekly.
That's not enough, is it?
I mean, that's 30 minutes of exercise.
And we're not talking about NEAT.
No, cardiovascular. No, not NEAT. No,
Okay.
cardiovascular exercise.
Uh-huh.
Oh, I'm glad you brought up NEAT.
Okay.
So
Okay.
that because so 150 minutes of cardiovascular exercise. So that's like 30 minutes 5 times a week.
Right.
But cardiovascular, like you gotta exert yourself a little
Like
bit.
sweat.
Sweat. I mean, sweat is relative. Right? You gotta push yourself.
Okay.
Right. About NEAT. So a lot of patients that come to the office is like, hey, I work in construction.
Right.
So I already do a lot of exercise. And what I tell my patients is like, you know what? Grab this water bottle and start doing curls. How many curls do you think you can do? They're like a million. Be like, exactly. Now grab a 40-pound dumbbell and start giving me curls. How do you think? How I start making, curling? How do you think you can do? How many do you think you can do? And be like, I don't know, 10. Like, exactly. When it comes to exercise, intensity matters.
Right.
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 You don't have to. You don't have to kill yourself running, but you do have to exert yourself. The quality of exercise is important. That's a key word, quality. And patients be like, no. You know what? I don't go around and walk 2 miles, but I do move a lot around the house. Like, okay. Okay, the quality of that's neat, but that's not quality exercise.
Right.
That's you have to exert yourself. So at least 150 minutes of that. If the more you do, the better, of course. The best benefits were shown on people who actually did twice that, 300 minutes of exercise weekly. And then they also described that you should do resistance training. So body weight, weightlifting, dumbbells, bars, whatever you like, but some sorts of resistance training. Movement is very important for us as humans. If you see the brain, this has changed a little bit, but the way it was conventionally thought is that you have areas in your brain that are related to speech and to movement. The areas of movements are really big. Like if you see they're a big part of our brain.
Of course.
So, and there's really cool studies that show that patients who perform resistance training during their life have lower incidence of dementia. So Alzheimer's, Parkinson's, things like this. So the American Heart Association recommends at least 2 sessions of resistance training during a week. So to sum up the question, I talked too much. I'm sorry.
No.
to
You're here to
condense
talk.
it.
You're here to talk. No, you're fine.
But to condense it, you should do at least 2 sessions of resistance training. 2 sessions of resistance training once a week and 150 minutes of exercise weekly.
According to
the American Heart Association.
Do you know people who? Well, what's the second thing? Because I think you said there were 2 things.
Yeah. So cardiovascular exercise. So that means running, jogging, swimming, and resistance training. So
okay. So let's go back to the construction site. Right. These guys are oxes. They're super strong.
No,
they're drilling. Absolutely. They're breaking ground, asphalt, laying down concrete, but yet they're still obese. They're still suffering from high blood pressure, right? And you can sit down and look to see what's on their fork and knives during their lunch break. It may not be the best food.
Absolutely.
And you definitely see scattered bottles of beer, right, after their work. Is that contributing?
100%.
So you can be very active. There's a lot of football players that are dying at a very young age.
Yeah.
Right.
And actually, that's nutrition is such an important component. I would say it's even more important than exercise.
Right.
When it comes regarding obesity, when it comes regarding the subject of disease, nutrition is highly paramount. And I think there's a lot of tools right now. Like you can use YouTube and go into YouTube and learn about nutrition. But sometimes, and I see mostly like with patients, they're very concerned. It's like, hey, what can I eat that makes me healthy? And it's not what can you eat that makes you healthy or unhealthy, because in a way we always try to find a culprit, to find a bad guy for something. It's like, oh yeah, donuts are bad for you, or hot dogs are bad for you.
Right.
They're not necessarily bad. It's the amount. The amount of food that you eat. You can have a hot dog every now and then, that's fine. But if you eat 4 hot dogs, 10 hot dogs, and patients like, hey, I only eat rice and beans. But yeah, you're eating like a full bag of rice and 4 cans of beans. That's way too much for you. It depends. So it's always this quality. And sometimes we focus too much in quantity. You know what I mean?
Yeah. I know people, including myself. Okay, so let me just break this down. My brother has hypertension. My mother has hypertension. My father has hypertension. My aunt has hypertension. My cousin just died from a heart stroke. I have hypertension. I'm vegan. I do OMAD, 1 meal a day. I walk 20,000 steps per day, if not more.
Wow.
I exercise twice a day. I do the 75 hard. You know what that is?
Yeah.
This is my 3rd one. I haven't drank alcohol this year. The last time I drank alcohol was on my birthday, which is September 4th, which is in 2 weeks or so.
Hey,
And when I eat, I have kale or spinach, mushrooms, and tofu. It's usually what's on my plate. I stop eating rice. I get more than 10 minutes of sun because I work out outside and inside. So I get that vitamin D and, the contractions of the veins and capillaries and so forth. And yet, despite all that, and I say this because I'm sure there are people who are really trying to make a change in their lives, but they're not rewarded by the results that would put them one of the members of those blue zones that we know about with the Okinawas and so forth. What is the cause? Because at a certain point, I understand some people try to compete with the food that they eat by taking certain meds, right? The meds are supposed to solve the problems that they are creating for themselves by eating at the drive-through or by puffing that cigarette or whatever they're doing. What about those people who are trying to make that change but have yet to reap the rewards?
So sometimes I think you frame it beautifully.
Thank you.
But sometimes just luck too. I mean, you are a super healthy guy from what you just told us. I mean, healthier than 90% of the people that I know.
Right.
And you still have hypertension.
Still have hypertension.
Exactly. And I mean, it's genetics.
It could be genetics.
And I mean, you're not doing a bad thing, but still you have hypertension, right? I think one of the most beautiful examples that I was told about this is that I think I was in med school and we're doing rounds. We do rounds and rounds and rounds. Mostly what you do in med school is learn how to do rounds. And we're with this wonderful, she is a rheumatologist. And I remember that we saw this patient with hypothyroidism. So she was not producing enough thyroid hormone,
Okay.
and she had to take Synthroid
Okay.
to supplement her thyroid, right? And I
She
went
has
the patient,
Okay.
and the doctor told the patient, hey, you have to take Synthroid, and she was like, the patient was like, oh, she's super disillusioned. It's like, oh my God, no, what do you mean? I don't want to take medicine. That means that I'm weak and I'm getting old. And people don't want to in a way, people don't want to take their medicine because it conveys a sort of weakness. I don't know how to explain it, but that's what I've seen a lot in a lot of patients. And this lady, the doctor that I'm telling you about, she was like, you know what? I have hyperthyroidism, and I work out every day. I run like 4 miles every morning, and then I do weights. I go for a session of weightlifting after I finish in the clinic, and I have hyperthyroidism too. But you know what? I see taking the Synthroid, taking this medicine, as part of my routine. Mm-hmm. Like I couldn't leave without brushing my teeth or having a shower. Mm-hmm. What I need to be healthy is take this medicine.
Right.
And it's not because there's something wrong with me. It's because this is part of my routine, and that's it. And I think that our perception to medicine is seen as I have to take medicine because there's something wrong with me, and I don't want something wrong to be with my body, and I don't want to feel weak, or I don't want to die. Mm-hmm. So if I ignore this problem, maybe it will go away.
It'll go away?
Yeah, exactly.
That's what people think?
A lot of people think that. And a lot of people are very bad. And it's also a burden, like carrying these pills and forgetting them and making sure that you take them.
Consistency.
Yeah, consistency is key for everything.
Yeah.
So yeah, it's this thing that you have to be very aware that it's not bad for you. It's just only helping you live a better life, more quality, and enjoy the most out of life with it. And that's what we want to see with patients with PAD. Imagine you are not able to walk. Right? If you go to an elevator you went to an old building that has no elevator,
you gotta go up the stairs.
What are you gonna do?
That's what we did in Brooklyn. There are no stairs. I mean, there are no elevators in the building, 6 stories. So there are people out there that disbelieve that hypertension and all of these things don't really matter because they're doing all of these things.
I think that hypertension and diabetes, they're very particular because you don't get symptoms out of them.
Silent killers.
Yeah. You don't feel like, you know what? I feel like my sugar is 120. No. Definitely, you know what? My blood pressure right now is 110/72. You don't feel it, right? Unless it's like super high, and then you feel like ringing in your ears, and you see like little flashlights,
right? Or tingling feelings.
And some patients get headaches when their blood pressure is really high,
right?
But on average, if your blood pressure's a little bit high, you don't feel any difference, and that's what gets your heart, and that's what damages your arteries in the long run, because your blood pressure is high not just the moment they measure it. It's high 24/7 all the time while you sleep, while you shower. It's all the time is high, and that's when everything gets damaged. And that's why sweat inflammation occurs, and that's why plaque buildup occurs, and it's not a process that happened that since the moment you were diagnosed with hypertension, but it's been happening 40 years. And when amputation occurred, that's when patients say like, oh, why am I losing my leg? It's like, well, because you have this for 40 years and wasn't treated, especially in a disease that it's difficult to diagnose.
So going back to that, but before we go back to that, there was a thought that I had, and I talked to my friends about this stuff. I had a friend of mine. He said, "Oh, I feel fine." And I said, you never wake up in the morning and say, "Oh, my blood feels like the pressure in my veins and my arteries feel pretty high."
Yeah.
It's involuntary. There's no way for you to actually measure that. And people, when it comes to health insurance, don't get to check their glycemic index, right? They don't get to check their blood pressure or get support from the insurance companies to track their blood sugar levels and things like that until post being pre-diabetic, right? So how important is it that someone walks into your doctor's office and you see that they're pre-diabetic and they don't track it until they see you again? How important is it for them to know what's going on a daily basis? Because a donut today doesn't mean a donut every day.
Exactly. No, so what I really like statistics, because statistics, they have this power that they help you understand very broad concepts and like really bring them like in front of you, and they summarize everything so in a very very elegantly. So what I tell patients is like, you know what, like this statistics, you can look them up. I mean, it's just everywhere. Patients who have diabetes are twice as likely to develop heart attacks and strokes, even though the diabetes is well controlled. That's it. Right. So let's say that if somebody over 70 has a 20% likelihood of having a heart attack in the next 10 years, now probably it's a 40% likelihood if you have diabetes, if that person has diabetes. And that's super, super important. I think that this concepts of health, they're very out there. They're very esoteric and metaphysical. It's like, yeah, in the future, you can have an amputation. So part of your job is to bring it into reality and be like, hey, that can be you. Not in 20 years from now, but in a year from now, 5 years from now. But imagine how your life would change 5 years from now if you have you don't have a leg.
Right.
Right. So it's part of that job to bring it into reality, and especially that's why I think it's so important to connect with people, because I mean you're concerned for them, even though you just met them. You don't want people to go walking around with crutches or in wheelchairs,
right? Or being completely dependent on. Really, now someone is living two lives because they have to take care of you.
Exactly.
Right? A family member or something. You ever watch this show where these kids don't know how to act and they go visit a prison and the prisoners talk to those kids?
I've seen videos, but I haven't seen the show, but I think I know what you're talking about.
They're still on. Yeah. Like if you go on YouTube. And they called that show Scared Straight. Mm-hmm. So when they come into your office and you talk to them about the road, the path that they're on, and you tell them 5 years from now, you could be amputated, right? You could lose your limbs. Does that spark anything in them to make those changes? And have you seen statistically some major changes? Or most of these patients coming in, I know, I think when I spoke to Patty about it, she said 90% of the patients that go into the Miami Gardens offices are Haitian. Are a lot of them at some point, majority coming out without legs or without functionality?
Well, hopefully not, because that means that we're doing our job incorrectly.
No, but the scared straight part is what I'm referring to.
No. I know what you mean. So it's a balance. Like medicine, it's hard in that sense because you don't want to freak people out.
Right.
You don't want people to think like, oh my God, I'm gonna check my blood pressure every 10 minutes or I'm gonna have an amputation. Oh. You don't want to convey you want to convey a sense of urgency, like, hey, this is happening, but we can change it. We can make it better, right? You can relay that message to the patients, but you have to do it in a way that you show them that if they don't change, if they don't take their medication, if they don't change their lifestyle, that can happen. So, that's part of the art of medicine. I don't go and just every time a patient comes, I don't have a script like, 5 years from now, you're going to have an amputation. And 5 years from now, you're going to have this. No, you're just like, hey, depending on, and you measure, like you're a guy, like if you came to the office, you're a guy who's educated, knows how to express himself. And if I tell you this and this and this, I tell you, hey, you know what? This can happen. And if I tell you, hey, you need to take that medicine. Let's try it for now. Let's see let's try to change this and this in your lifestyle. Let's see how it changes and how your markers change. You'll be like, oh, okay, yeah, I think I can do that. But if you have somebody, who they are not very educated in the sense of biological sciences, like medicine. Like they can be excellent mathematicians, or like a Nobel Prize in physics. But when because biological sciences have a lot of gray areas,
Right, of course.
so if you try to convey that message to them, it's like, oh yeah, I don't understand, whatever. I'm not gonna follow what you say, or I'm not gonna follow these recommendations. Then that's when you try to show the patient the information. And at the end of the day, you in medicine, you tell patients what that, like, you try to get the evidence, the data, and the science, and present them to them in a way that it's understandable and that it's comprehensible. And the patients, it's their lives. Some patients don't want to change, and we gotta respect that too.
They're adamant about the insulin next door is what caused the problem.
And if that's the happiness they want, who are you to try and strong arm them into doing what you think is right?
You're not there to argue, right?
Exactly.
Yeah.
They come here because they trust what you learn and what you know, and that you have good intentions, and you try to convey that message in a way that's and in receivable, and also that it adapts to your lifestyle. So I don't know if you are like a professional. I don't know. You're like one of these guys who go into like professional eaters. They go to these food competitions.
Oh,
You're telling like, hey, you shouldn't eat a hot dog.
20 hot
like
dogs.
You're 20 or 40 hot dogs in a single sitting. And it's like, dog, that's how I pay bills.
Your body is a bill too.
so it's hard. But
so when people walk into the doctor's office, are doctors typically checking for PAD?
That's a good question. I don't think so.
So how does one say, I need to go to the doctor to see if I have any signs of that?
That's a good question. So peripheral vascular disease has this particular thing that I really like. Mm-hmm. And is that people attribute symptoms of PAD to older age and to old age. So, I'll give you a perfect example. Mm-hmm. We had this patient. She was like, hey, you know what? My family planned this trip to go to Disney. Okay. They're going to go to Magic Kingdom. But I saw that they were reluctant into taking me to Disney because I can't walk that long.
Right.
So, imagine, you've been to Magic Kingdom.
I've heard this, yeah.
So, imagine if you just have to walk all day. When you're in Magic Kingdom, you push like 30,000 steps or 20,000 steps for you.
I can do that.
But for us mortals, that's a lot.
Right. Right. It's a lot. It's more than 8 miles.
Exactly.
Yeah.
So when you take a 70-year-old lady and you tell them like, hey, you have to walk all of this, people are like, you know what? I better not take grandma because you know that she's old, so she can't walk. And when you see this patient and you perform the studies and you do the ABIs and all the studies that we do to diagnose PAD, they have PAD. Right. So when you're 70, you're not gonna walk as fast and as the same distance when you were young in your 20s.
Unless you're the older version of LeBron James.
Exactly.
Yeah.
But walking shouldn't be something that generates discomfort. This is something that shouldn't be laborious because it's something that's part of what we do as human beings. Right? It's like reading shouldn't be hard. When you can't read, it's like, hey, there must be something wrong with my eyes. Let me go to an optometrist or to an ophthalmologist. I might need glasses. I might have this. I might have that. Okay. Why walking should be different?
So if it's tedious for someone to walk, this should alert to them. Go check for PAD.
Absolutely. So there's several things that are very, very important to clarify with that. Is that PAD is usually a disease that happens in the older population. Okay. So technically speaking, 1 in 20 adults above the age of 50 have PAD. And as you get older and older and older...
Is there a weight thing that's attached to that? A weight, like obesity?
Yes, of course. Absolutely. Obesity, hypertension, diabetes, smoking, hyperlipidemia, all of the high cholesterol, all those things definitely add up and are correlated with that.
Okay.
But usually it's a disease that happens in older people, usually a little bit more in males than in females, but we see a lot of females with PAD too.
Wow.
Older population, older demographics, mostly Caribbean patients and African American patients are and Hispanics in general are more prone to having PAD.
Okay.
So I would and the way I like to describe it when we teach residents and fellows and other practitioners is that usually what people have, what they feel is that when they walk or they exert themselves, they feel discomfort. They can feel discomfort by either because it's painful.
Mm-hmm.
It's painful when they walk. They feel discomfort because they feel like they lose strength in their legs.
So it's giving up on them.
It's giving up on them, exactly. They feel that they feel like tightness in their legs, but while walking.
Not their hamstrings and lower back.
Yeah, no,
their quads.
Yeah, the quads, maybe the hamstrings, but
so typical from sitting though.
Yeah, with exercise, with exertion, it happens, and then if you stop walking, it gets better. So usually it gets better quite fast, like in around 10 minutes.
Right.
So what patients usually tell me is like, hey, you know what? A perfect example is like when I go to Costco or Walmart or whatever and go grocery shopping, I have to stop like 2 or 3 times before I reach. If I have to park far away, I have to stop 1, 2, or 3 times before I finally make it to the store. Because I feel my legs are either painful, they're weak, or it's just uncomfortable to walk.
The lifestyle here. So I'm from a pedestrian city, from New York City.
Yeah.
Here, and even perhaps in the suburbs and so forth, people park their cars as close as they possibly can to the front of the store, as if Whole Foods is a small store and they don't have to walk down all these aisles. Whatever age bracket someone is in, the range, they're doing significantly less walking. Are you seeing signs of people getting PAD at an earlier age, or is it still consistently an older thing?
So it's difficult to answer this question because you can have patients with PAD who are younger, but they're usually outliers.
Okay.
It's not a patient who it's not the average presentation of disease. You see mostly patients who are older. Mostly seniors are the ones who get it.
Okay.
Mostly, I would say.
Is there a pre-PAD?
Not specifically. So,
you can't catch it first.
It's hard because you usually don't see it, and in fact, the treating PAD is mostly linked to symptoms, right? So you have patients who, if you do a test to measure the blood flow into your legs, your numbers might be abnormal, but they tell you, hey, doc, you know what? I walk 10,000 steps a day.
Okay.
I feel great. Technically speaking, as per guidelines, because mostly what we do in medicine is directed by guidelines.
Okay.
Because that's like the best recommendation. That's like the best science condensed like in a document. The guidelines say that you should treat patients who have symptomatic PAD. Or, if they have an ulcer in their foot and they need better healing, then you can fix or provide medication for the patients to improve that. But on average, if a patient is asymptomatic, there's a very low likelihood that we do something as per the guidelines.
Okay. So they get diagnosed with PAD. What types of treatments do they get?
That's a good question. So you usually recommend lifestyle modifications, so exercise, walking, whatever kind of.
So this is beyond the medicine.
Yeah, absolutely. So lifestyle modifications, diet, exercise. If you smoke, stop smoking. If you have diabetes, improve how the diabetes is being treated. If hypertension is a thing, control the blood pressure, all these things. Then you can do specific medication for PAD. So usually we provide some sort of blood thinners, so antiplatelets and medications such as aspirin or you can
amlodipine and stuff like that. No?
yeah, clopidogrel, Brilinta.
Okay.
Or the guidelines now they like rivaroxaban. Well, you give medication.
So on and so forth.
Yeah.
Blood thinners.
And then other things that you can do are either interventions. So you can do surgical interventions. That means that they're performed by a surgeon
to remove the plaque.
Remove the plaque or create bypasses.
Okay.
So you just skip that area, and you can have bypasses in your iliac arteries, in your arteries in your legs, in your femoral arteries, or even below the knee. Or you can do minimally invasive procedures. So this is mostly what we specialize in, and what you do right now is like a cardiac catheterization.
Right.
I went for a cardiac cath. You can actually do that for your legs too, and there's no cutting, there's no incision, and you can fix everything from inside of the arteries. Recovery is great. Complications are very low, and patients actually do fairly well with those. But not all patients benefit from having revascularization, like minimally invasive procedures. Some patients need surgery, or not all patients need surgery. Some patients need minimally invasive revascularization. So upon those, you have to, of all the patients with PAD, you have to make sure that this one benefits from this one, and send them to the right guy to have it done, or the right, the right provider.
So once they get that treatment, they get that bypass of these isolated particular areas with the plaque. Does that now mean activate your lifestyle, or they have to start that lifestyle even before they get the surgery?
The sooner you can, the better, right? So if you can change your lifestyle, even before having PAD, amazing. But you are always and should always find a physician or a provider who is adamant about you improving your lifestyle, right? Because the thing about medication is that medication can even give you that extra help that you need. Like in your case, you take really good care of your health, but you still have hypertension. You can give you a little bit of medication to improve it. Or for somebody who doesn't change their lifestyle, is that bridge between being healthy and your decision of actively not improving your lifestyle.
Right.
That's what medication does. But lifestyle should always be paramount and important, and should always be performed. Should always be improved. There's very specific cases that you like patients to take it easy. They had really complex procedures. You don't want to exert themselves for particular reasons, but on average, you would recommend everybody to move more, eat healthier,
be more active.
Yeah.
So you have a nonprofit?
Yes. So, the American Heart Association.
Yes, of course.
Of course, they launched this initiative.
Right.
So these amputations were on the rise. A lot more people are getting amputations. So they say, like, you know what? Let's make it a goal to reduce non-traumatic amputations. So amputations by chronic diseases.
Non-traumatic amputations.
Exactly. So
how is an amputation not traumatic?
So if you
Isn't
have
that an oxymoron?
No. By trauma, I mean by accidents. So falling from a fifth floor, car accident, motorcycle accident. So that's in medicine we call that trauma.
Right.
So you're gonna have an amputation because you were riding a motorcycle too fast, you crashed, all the arteries are severed, there's no way to fix them. Boom, you have to amputate.
Right.
That's a traumatic amputation. Or you can have an amputation that is due to chronic diseases. All the arteries are blocked. There's no way to rebuild that flow. The tissue is dying. You have to cut it.
Okay.
Right?
Okay.
So that's a non-traumatic amputation.
Okay.
Right?
Yes.
And a non-traumatic amputation, so the goal was to reduce non-traumatic amputation by 20% from 2020 to 2030. And they stated that maxim into the US. It's like, boom, cardiologists, vascular surgeons, do this. General providers, general practitioners, do this. Okay. And we saw that in this mosaic demographic of Miami, you see Hispanics, you see American patients, like white Americans, African Americans. You see Haitians, you see Colombian, Venezuelans, Argentinians. All of these people have some sort of risk factor to peripheral vascular disease, and we wanted to bring that statement, that
Awareness.
initiative, that awareness that the AHA was stating into the Miami-Dade County. So we created something called the Miami Initiative to Stop Amputations. And with that, we wanted to replicate what that goal of reducing non-traumatic amputations by 20% in these 10 years into Miami, into Dade County. So we've been doing a lot of community outreach. We do educational talks in all around Miami, teaching patients about peripheral vascular disease, the risk factors of peripheral vascular disease.
In the form of workshops or in the form of
yeah, we do like health fairs where we do like free screenings, but also like I go there and give a lecture. We go to the correction center and educate the people of heart disease and peripheral vascular disease. We go to the police stations and we provide same and similar kinds of talks. And just to get the message out there, right?
Wow.
Yeah, and hopefully, the thing about healthcare, and especially in cardiovascular healthcare, is that everything is very it's very hard for you, let's say, to find or to reach the guy who can the provider that can fix your issue. So we call that access to care. And part of the Miami initiatives to stop amputations, well, of course, to stop amputations.
Of course.
Given in the name. But also to reduce the access to care. We want patients to see cardiologists and vascular specialists sooner. Because the way it actually works in most with most insurances and the way healthcare works in America is that, let's say you have an issue. You have to go to your primary care provider. That primary care provider refers you to a specialist, but they say that specialist is like, oh, you know what? We actually need to refer you to another specialist to do this. So in some cases it might be very fast, but in some cases it might take you months.
Right.
Like you started, hey, I have issues with my leg. I can't walk when I feel uncomfortable when I walk. Oh, you know what? They have to send you to the right specialist. So you might not have PAD. You might have an issue with your knee. So they sent you to a vascular surgeon. A vascular surgeon is, no, your vascular studies are great. So now you have to go to a primary care provider again. So your primary care provider is like, okay, your legs are fine, from like arteries and veins are fine. Let's find another reason. Oh, you know what? It might be sciatica. Let's send you to a neurologist.
Right.
And what you needed all along was an orthopedic surgeon. So it takes you months before you reach that guy. So what we want to do is that reduce the access to care, convey the message of this disease that people are not aware of it. General practitioners are not aware, and providers are not aware of it. So we try to have to teach providers, teach patients, and hopefully stimulate patients to access to vascular and cardiovascular specialists sooner.
So essentially with the providers, what we're saying is they may not be aware of the symptoms that they need to see in order to properly diagnose that they have PAD.
Yes, but also, I mean, being, especially like if you are like in primary care, being a primary care provider is hard.
Right.
Very hard, because first and foremost, we are very bad to articulate how we feel.
Right.
So if you go to a doctor's office, usually, or or whatever, they have to really grill you into asking the right questions.
They don't spend that much time though.
Well, it depends. Maybe you're really good at expressing yourself.
Maybe.
But you see patients, you are like, I see this every day. Like I see Dr. Martinez asking questions to patients. It's so funny. It'd be like, ma'am, from 1 to 10, did you get chest pain when you exert yourself? I'm like, well, you know what? The other day I was taking my dog out, and he started fighting with another dog. And then I noticed that the leash was broken. So patients started like grumbling, and that happens. We do that all the time. We do that all the time.
They don't have the words. They don't have the...
Yes. So part of that is, imagine doing that. Not just, I mean, we do it for the heart, but now imagine doing that for the whole body.
Right.
It's super hard. Yeah. So you have 20 minutes because that's what the insurance company gives you.
Oh, really?
Yeah, or maybe less.
I did not know that.
Yeah, talk with this patient. Figure out what's wrong. Well, they want to tell you about how their dog was in a fight. And in that very short amount of time, send them to the right person or find the right option or the right treatment for them. It's hard. It's a lot of work, and it needs you to be skillful, and it needs you to really know how to get the right amount of information, the correct information from a patient. So, so if a primary care provider is like, oh, you know what, I have to ask them about their heart, but how about their gastrointestinal system, but also about their legs. They'll be like, do you get leg pain while you walk? No. Fine. How about your stomach? Are you feeling good when you eat? Good. No. Okay. Do you get chest pain? No. Good. Oh, perfect. You know, it's also, I get it. It's a lot of pressure. It's easy.
A lot of pressure, and you might not be able to come up with that answer right away.
Exactly. It's in fact something really fun that happened when you're training, is that it might have happened to me. I'll never disclose this in public, but you go to a patient.
You're on.
but you go to a patient and you're like, madam, do you have hypertension? They're like, no. And then you see them and they're like, and then you come with your attending, the guy who's teaching you, and it's like, madam, do you have hypertension? Yes, I take this medication and this medication, and you presented it to the doctor to like, she has no hypertension. And he's like, you are terrible at performing interviews. You see that all the time, especially with nurses. Is that nurses, because nurses usually are the first to interact with the patient.
Right.
And then you see that the nurse goes and it's like, hey, sir, do you take any medication for your blood pressure? No. And then the physician comes, or the nurse practitioner comes, or the PA comes, and they're like, hey, do you ever take any medication for your hypertension? Well, actually thinking about it, I take something called Losart. And they're like, oh, you see, you didn't know how to interview this patient.
So what is it? Is that a psychological issue?
No, it's just, I don't know why. You see it so much. It's so
people
funny.
will literally either not, will not say or just acknowledge the issue first time, but then the role of the person that's coming up afterwards, they'll be more transparent.
No, it's not that people are like trying to not tell you things. It's just that when you start to really think hard about these things, is that when you are like, oh yeah, actually I do.
Right.
You know what? She asked me if I get leg pain when I walk, but actually I don't get leg pain, but my legs get tired. You start to think about these questions.
Right. You're giving them time.
Yeah, you give them time, and then that's when people come up with these answers.
Yeah, like in 20 minutes or even less,
it's hard.
You really don't have time to mull over everything that's going on unless you came in and you already say, hey, doc, here are my problems.
Yeah, and usually that never happens.
Right.
So it's hard for the providers, and it's hard for the patients to also like really like summarize everything that goes into their lives in 20 minutes or less. And, so that's why it requires a little bit more, awareness about different presentation of PAD, early access to care, because somebody who's a trained cardiologist, they know how to frame and ask the question in a way that makes you think or makes you come sooner to that answer. It's like, you know what? Yeah, I don't feel pain while I'm walking. What I do feel cramps while I'm walking. Is that PAD? Might be. Let's do some testing.
Right. Let's do some testing. So how do people get connected with your nonprofit?
Yeah, so we have a website. It's at amavitafoundation.org. There you can see and you can find information about MISA, the Miami Initiative to Stop Amputations. You can request a free screening if something that's interested, and if you feel that you have PAD. We have questionnaires. We got educational material for both providers and for patients. And hopefully with that information, you feel a little bit more secure about PAD. We also are still performing our program for community outreach. We're still performing screenings in the community. We're still giving talks and lectures in the community. So yeah, it's mostly through a website, also through amavita.health. If you have any questions, and you can reach us up through Amavita Foundation, you can reach us through there. It'll be either or, they are both connected, and we'll be happy to talk to you, teach more about PAD, and hopefully get you aware with peripheral vascular disease and why it's so important in Miami Dade County, but in as a general population, it's a true problem.
I mean, it's the United States is dying, right? Is there? I know you said you don't do this is your first time on a podcast, but do you guys have online content for people to really lock in and look at your mission?
Mostly on Instagram. We have a strong Instagram presence. I think it's called Amavita Health, right? You can find us there. We always are, showing a couple of statistics, because we don't like statistics in this,
They don't like statistics, but statistics, listen, if I had the WAMP, the Apple Watch, and all of these things, I think these are great IoT devices so that people can keep track of themselves. Because people think about what they've done, but they don't really know what they've done. They have conceptually, they believe they do certain things. Like, oh, I didn't eat anything today, but that was 8 hours ago. You may not remember what you consumed at 5 o'clock in the morning versus 10 o'clock at night. That could be a whole life.
Absolutely.
I love the name. Amavita, right? Vita is Italian for life.
All right.
And ama is, in many Latin languages, the word for love.
Exactly.
Right? So to love life, you guys have really captured the heart of it all.
Oh,
that's amazing. I love what you guys are doing. I'm looking forward to talking to you guys after this set to see how the Haitian community can provide a synergy with you. We have a portion of our platform that connects with medical doctors and so forth, because it's important for Haitians to have access to medical services. I mean, our health is primary. Yes, you have to work, but you have to be able to provide for yourself, not only now, but then the future version of ourselves. I think we're always needing to double our salary, because there's going to be a time where we can't go out and work and take care of ourselves. And if we have children, if we have parents, then we're going to need to be able to physically be able to move around and take care of ourselves. And you can't love life if you're in pain all the time, if you're not feeling well all the time. So thank you so much.
Thank you for having me.
For being on our show and cascading this light of knowledge on us.
Thank you so much for the invitation.
Thank you again. And how can people find you on? I saw the YouTube video of you guys in Haiti. Dr. Martinez was in Haiti, PMC. So we call him, he was in Haiti. He took that trip. That was amazing. I would love to see more content like that. And I just hope that you guys document as much as possible, because it's so important what you're doing. People undervalue knowledge simply just by going to a restaurant and going into the fridge and going into the aisles and picking out food with so much sodium, so much sugar, and they don't understand how damaging they are. And you know what's ironic about all of this? The less active you are, the more you eat, I suppose. I don't understand how we need food for energy, but we're not even trying to utilize it. So again, thank you again for the time.
Thank you. Thank you so
all right.
much.
And that's it. So once again, if they want to find you, AMAVITA .health. If they want to, where are your offices?
So we're mostly located in the Northeast.
Okay.
So mostly 3801 and Biscayne. You can find us there. We got a strong presence in Miami Shores and in North Miami. We'll be happy to see you. We'll be happy to take the time and explain you a little bit more about PAD and cardiovascular health in general. You know, they are all very related. So issues with your legs can yield to issues in your coronaries. So hopefully you can come to a place where we can really take care of you in a cardiovascular setting as a human being and not just left leg, right leg, heart. So yeah.
You have a sign on the door that says, "Si habla criollo, está bien."
Sí.
Okay, thank you very much. And that's it.
All right.
Thanks again.
Hey.
All right.